Welcome to Hiranya Medical Service.
A very good evening to all of you. I'm Dr. Vivek Iyer. I'm a consultant neurologist at SIMS Hospital, Chennai. At the outset, I would like to thank Hiranya Medical Services for organizing this talk and for giving me the opportunity to speak on, give a brief overview of Parkinson's disease. So, considering the fact that this is basically catered to uh, uh, general public, I would try to keep it very simple with some specifications which would be useful for the budding doctors. So, yeah. So, overview of the talk, I would be focusing on briefly history, pathophysiology, symptoms, and an overview of medical and surgical management. So, James Parkinson's first described his essay on what he called as shaking palsy. It is also called as paralysis agitans. So, what he described as early as 1817 is that the patients had involuntary tremulous motion with lessened muscular power in parts not in action even when supported, the propensity to bend the trunk forwards and to pass from a walking to a running pace, the senses and intellects being uninjured. So, what an apt description of what the patient of how a patient of Parkinson's presents with 200 years ago. Jean Martin Charcot proposed its current name, honoring James Parkinson's as Parkinson's disease. So, what basically happens in Parkinson's disease is there is loss of dopaminergic neurons in the substantia nigra. So, what goes wrong here is you consider that there is age, genetic, and environmental factors. There is free radical mediated damage, glutamate excitotoxicity, ion related excitotoxicity. So, what happens is there is presence of alpha synuclein, so protein aggregates, alpha synuclein, which go on to form the Levy bodies, which are actually composed of alpha synuclein filaments. So, this alpha synuclein, when aggregated, causes free radical mediated damage, oxidative stress, lysosomal dysfunction, mitochondrial damage, and glial activation, which ultimately leads to apoptosis and neuronal cell death, which leads to the Parkinson's disease symptoms. So, this is basic pathophysiology of Parkinson's disease. So, biochemically, what goes wrong is there is a direct pathway which is from the corpus striatum to the globus pallidus interna, substantia nigra reticulata part, thalamus, which relays back to the cortex. Direct pathway is by and large excitatory. It is important for voluntary, purposeful movements. Inhibition of the unwanted movements is brought about by the indirect pathway, which involves the substantia nigra compacta, striatum, globus pallidus externa, subthalamic nucleus, which then relays on to the GPI SNR and the thalamus and back to the cortex. So, what happens in Parkinsonism is because the substantia nigra pars compacta is diseased, the excitatory output reduces, the inhibitory output increases initially. So, what happens is there is increased activity in the indirect pathway and reduced activity of the direct pathway, leading to loss of or reduction in purposeful voluntary movements and presence of abnormal hyperkinetic movements, resulting in tremor. So, if you see the symptoms of Parkinsonism, go back to the original description by James Parkinson's in the essay. So, tremor, which is usually a rest tremor, which is usually called as a pill rolling type of tremor, starts one side asymmetric before progressing onto the other side. There is rigidity, which is reduced stiffness of the limbs and trunk, which is brought about by what we call as Froment sign. So when a patient is sitting, you ask him to open and close the fist, and you check for rigidity in the opposite side. So it can be of two types, either lead pipe rigidity or cogwheel rigidity. So lead pipe cogwheel rigidity is because of superimposed tremor, akinesia or hypokinesia or bradykinesia. So loss or slowness of movements, and a stooped posture and balance issues. Okay, so bradykinesia plus any of the three is a sine qua non for the diagnosis of Parkinson's disease or Parkinsonism. So there is a stooped posture, reduced facial expression, anti-collis or forward trunk tilt, neck is pushed forwards, flexed elbows and wrists, reduced arm swinging, trembling of extremities, short stepped gait. Sometimes they can have a festination gait in which they seem to run rather than walk. And there is a gait freezing. Sometimes they just get stuck for a minute without being able to keep a foot forward. Of course, that happens as the disease progresses, pathologically and clinically. So, while most has been discussed about the motor symptoms of Parkinson's, the non motor symptoms of Parkinson's need a special mention because non motor symptoms are what comes into light or what comes into a clinician's mind when we talk about Parkinson's is the tremor, the rigidity, the bradykinesia, and the postural instability. But non motor symptoms are equally important because they are debilitating. Hyposmia, plethora of neuropsychiatric disorders, depression, anxiety, impulse control disorders, which can be exacerbated by dopamine agonists, cognitive impairment, evolving into the Parkinsonism disease dementia complex, autonomic disorders, usually not seen early on in Parkinson's disease, can be seen in multiple system atrophy early on. So, heart rate variation, urinary urgency, urge incontinence, sexual dysfunction, orthostatic hypotension, constipation because of uh, reduced peristalsis is a very, very important and a very, very common complaint that these patients come with. And sleep disturbances. So REM sleep behavior disorder can be there, which can usually antedate the presence of motor symptoms by even 5 to 10 years. Fragmented sleep, excessive daytime sleepiness, and other sleep disorders can be there. So, to call a patient as Parkinsonism, it is TRAP, tremor, rigidity, bradykinesia, postural instability. So bradykinesia plus either rigidity or rest tremor is Parkinsonism. But Parkinsonism and Parkinson's disease are not the same. So, Parkinson's disease, so you have supportive criteria, exclusion criteria, and red flags. So, clear and dramatic response to dopaminergic therapy, presence of levodopa-induced dyskinesias, documentation of resting tremor, and either hyposmia or cardiac sympathetic denervation on an MIBG scan are the supportive criteria. Red flags, rapid worsening of gait, or no motor progression over 5 years. Early bulbar respiratory involvement, autonomic involvement, recurrent falls. These fall into a rubric of Parkinsonism plus. Disproportionate anticollis, MSAP. Absence of common non-motor features in more than 5-year disease duration. Presence of pyramidal tract signs and bilateral symmetric presentation. As I said, Parkinsonism is by and large asymmetric to begin with. The absolute exclusion criteria include cerebellar signs, gaze palsy, established diagnosis of behavioral variant of frontotemporal dementia, restricted to lower limbs for more than 3 years, history of treatment with dopamine depleting agents, poor response to syndopa, presence of cortical sensory loss, and functional imaging shows no evidence of dopaminergic deficiency. So, clinically established PD requires absence of absolute exclusion criteria, at least 2 supportive criteria, and no red flags. Okay. So if there are 1 red flag or more than 1 supportive criteria, or 2 red flags with more than 2 supportive criteria, it's clinically probable PD. So now, having given a brief overview of the clinical features, let us go to the therapy part. The essence lies in dopamine. So you have the dopamine, which is not crossing the blood. L-dopa, the levodopa, is a precursor of dopamine. Dopamine cannot cross the blood-brain barrier because it has a peripheral dopa decarboxylase. L-dopa cannot cross the blood-brain barrier. Dopamine. So L-dopa, levodopa, is decarboxylated by dopa decarboxylase to dopamine, which is in fact responsible for the adverse effects. Once the dopamine reaches the brain, again the L-dopa, levodopa reaches the brain. It is converted to by dopa decarboxylase to dopamine. And at each step, you have the monoamine oxidase inhibitor, the catechol orthomethyltransferase inhibitor, and the dopa receptor agonists, which essentially are the main areas of target in Parkinson's disease. So, those which act on dopaminergic pathway or non-dopaminergic pathway. So, levodopa, what it does, it increases the endogenous production of dopamine. Mimic the effect of dopa is dopa agonists, ropinirole, pramipexole, lyserolide, pergolide, etc. Prevents degradation of endogenous dopamine is MAO-B inhibitors, and prevent degradation of exogenous dopamine is catechol orthomethyltransferase inhibitors and amino acid decarboxylase. It is dopa decarboxylase inhibitors. It is the carbidopa and benztrazine. Anticholinergic action with trihexyphenidyl and blockage of glutamate receptors is with amantadine. So, levodopa is the mainstay of treatment in Parkinson's disease, and no drug in Parkinson's disease or Parkinsonian syndromes produces as much motor response or as much symptomatic response other than levodopa. So, dopamine cannot cross the blood-brain barrier, as I said. So, levodopa is actively transported by dopamine transporter. But what we need is carbidopa also along with levodopa. Why? Because otherwise it is decarboxylated in the periphery. So either it is a 1:4 ratio or a 1:10 ratio of levodopa and carbidopa. So addition lowers the dose of levodopa. Peripheral side effects are reduced with, otherwise dopamine which is generated in the periphery will lead to all side effects. Nausea, vomiting, arrhythmias, hypotension, etc. If you see bradykinesia, more than rigidity, more than tremor. This is a sequence of response. Tolerance develops to both the effects. It's most effect in the first 2 to 5 years. Take on empty stomach because food limits absorption. Apart from the normal peripheral side effects, initially it can cause some tachycardia, orthostatic hypotension. Dreams, delusion, hallucinations are well known. Now, as the Parkinsonism advances, what happens is the stores get so much depleted, the dopamine in the substantia nigra gets so much depleted that the body has to depend on the exogenous dopamine which is given. The moment you give the dopamine, the patient starts responding in terms of symptomatic improvement. The moment the dopa levels go down, the patient becomes slow. So it is called as motor fluctuations, which can be wearing off because of the presynaptic changes which are occurring, delayed on because of delayed gastric emptying and intestinal malabsorption. Sometimes the patient does not get on, that is dose failures, and random off due to long-term striatal pharmacodynamic changes which occur. So this leads to dyskinesias, also motor fluctuations. It can be peak dose dyskinesias which are related to syndopa, or end of dose dyskinesias which are related to the wearing off of syndopa, or when the drug levels come down, a biphasic when the drug levels go up and when the drug levels come down, both types. Each of which has to be analyzed clinically for coming to a diagnosis of drug-induced or levodopa-induced dyskinesias, and accordingly the treatment varies. For want of time, I am not going into the details of how to manage the motor fluctuations. I'm just going to give a brief overview. Next, so how high can you go? We usually start off with 125 milligram, 110 milligram, half BD or half TDS, and gradually escalate the dose as per patient's tolerance. Usually we give the drug 1 hour before or after food as food limits absorption. And make sure you don't give any vitamin B6 containing substances, pyridoxine containing substances along with levodopa, because it is a cofactor and it will increase the degradation of levodopa. Dopamine agonists, D2 receptor agonists, they are useful because they augment the action of levodopa. Initially can be used as monotherapy in young onset Parkinsonism less than 60 years of age. But once, because there are less dyskinesias, less motor fluctuations, specific side effect is impulse control disorder or hypersexuality. So pramipexole can be given to a maximum of 4.5 milligram per day in 3 divided doses. Ropinirole, although the books say you can go up to 24 milligrams, but in reality, not more than 4 to 6 milligram most of the patients tolerate. These dopamine agonists are the drug of choice if the patient has predominant REM sleep behavior disorder, RBD, dream enactment, vivid dreams, nightmares, etc. COMT inhibitors, they reduce the breakdown of levodopa. So there is a smoother blood levels, reduced motor fluctuations. You have to watch for diarrhea. It improves the on phase. So it is usually given along with syndopa. Tolcapone was withdrawn from the market because there is fatal hepatotoxicity. Entacapone can be usually given. It causes diarrhea and GI disturbances. Usually tablets are available in combination with levodopa carbidopa as Syncapone 100, 50 or 200, or by the trade name of Entacom, which is a 100 or 200 milligram tablet, which is usually given along with levodopa to augment the action of levodopa. MAO-B inhibitors, again, prevent the degradation of levodopa, so enhances the anti-Parkinsonian action, can be usually monotherapy, they are not given as, they are used for on-off or wearing off phenomena. Selagiline was earlier used 0.5 to 1 milligram BD. Now we have a new drug that is Saphenamide, sold by the trade name of Zafinac, which is usually given as 50 milligram initially, and once the patient starts tolerating, 100 milligram can be given. Last is a novel drug, amantadine. It improves delays the dopa reuptake from the dopaminergic nerve terminals, and is an anti-glutamate, a strong anti-dyskinetic. So when the patient has levodopa-induced motor fluctuations and dyskinesias, this is a must drug to be added. Hallucinations, period edema, and rubella reticularis are known complications, and it is usually given as 100 milligram BD or TID. Nowadays, extended release preparations are available as amantadine ER tablets, Parkinson ER tablets, 129 and 193 milligram. Anticholinergic agents are drugs of choice in drug-induced Parkinsonism or in tremor-dominant Parkinsonism. So tremor, more than bradykinesia, more than rigidity, exactly opposite to that of levodopa carbidopa. This is based on the assumption or based on the hypothesis that deficiency of dopamine augments the excitatory cholinergic system. But you have to be cautious when you give to elderly people, because anticholinergic, they can cause urinary retention. And most of our elderly patients have prostate-related issues. Now, once the patient has sort of crossed 3 to 4, 5, 6 years into Parkinson's, has disabling motor fluctuations, dyskinesias, with a good response to levodopa carbidopa therapy, with no major cognitive or psychiatric comorbids, then he is a candidate for deep brain stimulation. It has been started in India in Mumbai by Dr. Mohit Bhatt and Dr. Paresh Doshi's group as early as 1999-2000. So what is done is we target the globus pallidus interna or the subthalamic nucleus. So what is actually done is the electrode is placed there. Of course, before that, we have a navigation protocol, MRI done, and we fuse and locate the subthalamic nucleus. The microelectrode recording is done. The electrode is put there, and the lead is tunneled through the small hole, a borehole in the skull, and the lead is under the skin, which is connected to the implantable pacemaker. Initially, by the lesioning effect, what happens is usually for 2 to 3 weeks, the patient's symptoms remarkably come down. Then after 2 weeks, we start the programming, switch the pacemaker on, and then adjust the pulse width, frequency, and the amount of current which needs to be delivered. So Inclusion criteria, L-DOPA responsiveness is important. So you do a UPDRS 3 scale, that is a Unified Parkinson's Disease Rating Scale. You do the motor component in the on phase and the off phase. Off phase means 12 hours of levodopa and challenge them with a supramaximal dose up to 1.5 times their usual dose, which they take in the morning. Then you do an on phase, off phase UPDRS initially, and then an on phase UPDRS, and that should be 33% improvement in the motor UPDRS score 12 hours of medication. That is taken as positivity. Absence of dementia and psychiatric illness, as I already told you. Atypical Parkinson's, poor L-DOPA response, associated dementia, severe psychiatric comorbidities are exclusion criteria because patients don't do well. So ideally an age less than 75, idiopathic PD, L-DOPA responsive with disabling motor fluctuations, dyskinesias, a good improvement in the motor UPDRS score, MMSE being normal, no comorbids, and the patient should be willing for surgery and programming because it's an expensive uh, deal or an expensive procedure costing around 10 to 15 lakhs, and the battery has to be changed after 7 to 8 years. So what target should be chosen? So a brief overview, as I said, STN or GPI. So mostly we do STN DBS. Okay. There is a theoretical risk of cognitive and mood decline, possible risk of falls, but the programming complexity is there, economically little feasible. Okay. But overall, both of them equally affect the motor symptoms, rigidity, tremor, bradykinesia, and a great improvement in the quality of life. So, summarizing, Parkinson's disease, we've come a long way from the essay of James Parkinson's describing the classical clinical features to the DBS era, wherein we have a potential, I wouldn't say a cure, something sort of a cure for the neurodegenerative disease. And trials are, uh, uh, various researches are going on in the field of Parkinson's to identify newer and newer drugs which will alleviate or which will lessen the motor complications of Parkinson's. Because if you look for close to 45, 50 years, we only were banking on levodopa. So ultimately, either you start off with a dopa agonist or an anticholinergic or a MAO-B inhibitor. Ultimately, when the patient lands up with levodopa-carbidopa combination and then lives a life full of disability and motor complications. So the advent of DBS has definitely changed the way the clinicians, the neurologists, the movement disorder specialists look at Parkinson's. And of course, from the patient's point of view, there is a hope that the patient can be cured of the Parkinsonism. Thank you.
Thanks for watching. Do like, share, subscribe, and click the bell icon button to receive instant updates.